Hi, I'm Dr. Mila Brujic, and welcome to the American Academy of Optometry Foundation clinical podcast series, where we're going to be doing a deep dive into corneal reinnervation. With us, expert Dr. Andrew Pucker. Dr. Pucker, can you please give the audience just a little bit of a background on yourself and really your experience and what you've done with your career up to this point, and where you currently are, what you're currently doing?
Sure. My name is Andrew Pucker. I'm currently the Executive Director of Clinical and Medical Sciences at Lexitas Pharma Services. I'm, of course, an optometrist and fellow. I did my training at Ohio State, where I got an ODMS and PhD. And I really have done a lot of research over the years, and that is kind of why I'm at Lexitas. And with that position, I've had the opportunity to be a medical monitor on two different NK studies, and that's partly why I'm here today to talk to you.
That's great. We are certainly learning a lot in the last 5 to 7 years about corneal innervation, so much so that I think even in addition to hypercorneal sensitivity, or sometimes what we refer to clinically as neuropathic pain, is neurotrophic keratitis, really the loss of innervation. That's what we're really going to be doing a deep dive into here. This paper is entitled Corneal Reinnervation in Patients with Severe Neurotrophic Keratopathy, Secondary to Herpes Zoster Ophthalmicus, after treatment with Autologous Serum teardrops. So, Andrew, can you share with us a little bit why this paper in particular is so important to optometry and how we're caring for our patients?
Sure. So NK or neurotrophic keratitis is a fairly rare condition, but you're probably going to see it at some point in your career. And it may, be getting more common as people get sicker, more people have dry eye, more people are getting viral keratitis. And actually, the focus of this paper is patients who have neurotrophic keratitis from a viral eye disease. I've actually had shingles myself. I have a little bit of nerve paralysis from that in my face. So it's like a personal, kind of catch for me, but it's just going to keep getting worse, I think.
And Andrew, discuss a little bit about autologous serum teardrops and really what they are, how they're formulated, and why they're starting to really kind of gain the interest more so from clinicians.
With this, it's been around for a while. So autologous serum has been around for a while, and we commonly use that for really severe dry eye. And the reason we would do that is because when you take some blood from yourself, you can have it spun down, and then you have the serum left, and that still has growth factors in it. And that is really something that's absent in patients with NK. They're not having enough growth factors on their eye to tell it to stay healthy. And because of that, they have these persistent epithelial defects that can be extremely painful, or maybe if they have nerve damage, maybe they have no pain. So they're a little bit tricky to diagnose, but really the key sign that you need to look for in these patients is that they have a corneal epithelial defect that's open for at least 10 days, and it doesn't generally heal with, your typical medications.
So, Andrew, can you do a little bit of a deeper dive into why herpes zoster causes neurotrophic keratitis? You did a nice job of overviewing it, but why does this physically cause this?
A patient who has a zoster's flare-up actually is having nerve damage. So these viruses live in the nerves, and then they are reactivated. For me, I was immunosuppressed, and that's partly why I got shingles. And when that happens, the viruses cause a lot of inflammation damage, and it can actually kill the nerves. So with neurotrophic keratitis or in patients who have it from zosters, they actually have just dead corneal nerves from this condition, and they may or may not ever come back.
It is interesting so there's a lot of discussion in the eye care space right now around dry eye. And one of those critical signs, as you're well aware, is corneal staining. And we've always kind of floated this term around stain without pain, but we certainly are taking or putting more attention towards it because of these options that we have to treat this condition. Heading back to the paper, just a little bit more focused here. How was improvement assessed in the study? So they treated these individuals with autologous serum drops, and you're going to go into that in just a second. But how were they measured for improvement?
So backing up one step, I believe you mentioned that we're looking at these dry eye patients, and we are starting to notice that, hey, maybe advanced dry eye has some overlap with neurotrophic keratitis. And specifically, when we're thinking about evaluating neurotrophic keratitis, there's something called the Mackey scale. And the first stage of the Mackey scale is essentially a lot of SBK or staining. And maybe those people are on the pathway to NK. And that's something I think we should have in our mind when we're looking at a dry eye potential subject, 'cause maybe they actually have something more than that. And maybe they'd be a good candidate for someone who's, or for something like oxybate. So that's one thing. But talking about your specific question, so how do we evaluate these patients? Well, we want to look at corneal sensitivity, and of course, we want to look at, is there a lesion or not? So with corneal sensitivity in clinic, we typically use something very simple. It's called a Cochet-Bonnet device. It's essentially a wand with a long thread on it. So when the thread is at 6 millimeters, that's all the way out, and it's a very small amount of pressure. And you actually touch that to the patient's eye, and if they can feel it at that point, that's a normal eye. But you keep making that thread smaller and smaller, shorter and shorter, and say it's at like 3 millimeters or so, you touch their eye and they can't feel it still. That would be an abnormal patient, and you really want to worry about corneal sensitivity at that point. Also, if you were inside a kind of a research setting, you might have something advanced like confocal microscopy to see if there's actually nerves there, and that's actually something that was also done in this study.
So, Andrew, these patients, they came in with this neuropathic, neurotrophic keratitis, secondary herpes zoster. So they were treated with autologous serum eye drops. Can you just go over how many times they used the drops, how long they followed the patients, what were the results? And can you also comment on some of the stromal thinning that they saw as well, too?
For sure. So what they did is they had patients take autologous serum, so 20% autologous serum 8 times a day, so a lot of times a day. They had 4 patients in this study. It was essentially a case series. And what they did is they treated them, and 3 out of 4 of them responded really well. So they had these patients who started with basically no corneal nerves as evaluated with the confocal microscopy. Over the course of the treatment, they had nerves regenerate in actually all 4 patients. And in 3 of the 4 patients, they regenerated to the point where they started to be able to feel their eye again. So it's really cool.
That's great.
Uh,
And then can you comment on some of the stromal thinning that was seen?
yes, of course. And in the 3 patients who got better, they started to have some corneal thinning and inflammation. And what they thought was that was a sign of healing. They weren't expecting it initially, but what they did is they started to treat them prophylactically with antivirals and then with a steroid, and that actually got better. So actually, I think we should really watch out for that if we take this approach. It may seem scary at first, but it's actually should be anticipated, and a good thing, it's showing that they're healing.
That's great. So it shows the efficacy of autologous serum in these patients that are sometimes most vulnerable to actually rehabilitating that cornea and the nerve structure and the plexus that actually is most important to keeping that corneal tissue regular and healthy. I think that's a big clinical win for us. Andrew, is there anything else from the study that you'd like to share? Any other thoughts on this topic?
Well, these are tricky patients, and we don't see them every day. So I'd like to encourage you to, be brave and try this. But if not, if you're worried that they may have, NK and you don't know what to do, just refer them to someone who's good at it. There's a lot of people out there who have a great interest in this. And if you do that, they'll probably stay with you for life, because these are people who've maybe been to several other doctors that weren't treated properly. Maybe they didn't know quite what was going on. And if you actually get them the diagnosis they need, they'll love you forever, probably.
Andrew, it's always a pleasure talking to you, and in particular on this topic of corneal health. Thank you so much for being on this episode.
Thanks for having me.
And thank you all for joining us on this episode of the American Academy Optometric Foundation Clinical Podcast Series.